Hello and welcome to part 3 of Human Growth and Development and your very last AP2 lecture. Very exciting. Okay, so we're going to talk about sexual differentiation in the embryological period. And so there's kind of 3 phases to this. There's genetic sex, which is actually going to be determined at fertilization. And so it's going to be the male contribution that determines the gender of the offspring. So there are X sperm and there are Y sperm. And so the ovum is always only going to contribute an X chromosome. So if it's a Y sperm, then you have a male. If it is an X sperm, then you get the production of a female. So right there at the formation of a zygote is genetic sex. There is a gene that is only on the Y chromosome called the SRY gene. It stands for sex regulating region. And so it is this region that is going to bring about gonadal sex. And so once we have gonadal sex in the male, we'll have testes, then we have testosterone production. It's going to be testosterone production that is going to drive the changes to bring about phenotypic sex. And so, internal and external male genitalia. If it is a X sperm, then we have a female zygote, and then there is no SRY gene. So there is no signal. We won't get testes production. We will get ovaries being produced, and those ovaries then will produce the female sex hormones, estrogen and progesterone. So in an absence of testosterone, you get female phenotypic sex. And so we're going to kind of look at that a little bit more. Okay, so about the 6th week is when we're going to get sexual differentiation and reproductive development. And once again, this is all going to be because of the presence of that Y chromosome, and particularly the SRY, so the sex regulating region of the Y chromosome. So up until that time, though, you can't tell the difference embryologically or histologically is what I mean. And so you're going to have the early gonad formation. You have something called Wolffian ducts. You're going to have something called Müllerian ducts. You get the early bladder, the probladder, you can see that. And then you have kidneys and the structure called the cloaca. And so if there is a Y chromosome, then we get the SRY gene turns on. We're going to get testes development. And then what's going to happen is we are going to get a regression of these Müllerian ducts. So these are going to go away. And so it's only the Wolffian ducts that you see right here. They're going to develop in the epididymis. You see the ductus deferens, and then we're going to have the urethra. And so it's just kind of showing you that development. But it kicks off about week 6. So then you come over here. If there is no Y chromosome, then we don't get testes development. We don't have testosterone being made. And so what's going to occur, those Wolffian ducts are going to degenerate. And from those Müllerian ducts, we're going to get the uterine tubes, and the uterine tubes fuse and form a uterus, and then we get female reproductive structures. So if we look at the external genitalia production, once again, this is all kicking off around week 6 with that turning on of the SRY gene. And so we'll go over here. So now we've got testes, we've got testosterone being produced. And it starts off, we have this genital tubercle, we have something called the urogenital groove, and then of course this would be the anus. But it's showing you that genital tubercle in the males is going to become the glans penis. That urogenital groove is going to fuse and become the shaft of the penis. Over here in the female, that genital tubercle is going to become the glans clitoris. And so this is where, all that talk about the homologous structure is coming from when we were going through these reproductive the reproductive organs of both male and female. So it's going to fuse in these other urogenital folds. This will become the scrotum. Go over here in the female. So this urogenital groove is not going to fuse all the way in females. So you're going to get opening to the urethra and the vagina, and that's going to make up the labia minora. And then the labia majora, that was why I was saying is homologous to the scrotum, because it comes from the same embryological tissue. So this thing, testosterone leads to male genitalia and internal structures, and without that testosterone, you end up with female structures. Okay, so sit back and relax and watch the tale of Why Do Men Have Nipples?
Evolution explains a number of fascinating facts about the world we live in and the strange creatures to be found here. From why the Cameroonian horror frog can break its own bones to produce claws, to why the horned lizard shoots blood through its eyes. Science has an answer to the strangest phenomenon, but there are still quite a few natural quandaries that leave some of us totally stumped. For example, why would a male animal have prominent features only required by the female of the species? Can this strange biological quirk be explained by science? Why do men and women both have breasts? In this episode of the Infographic Show, we explain just why do men have nipples. First of all, why do human beings, male and female, have 2 nipples? Why not 1 nipple, or 3 nipples? Well, it seems that the general biological rule of thumb is that a mammal ordinarily has twice as many nipples as it needs to feed its offspring. Cows often give birth to twins, so they have 4 nipples. A small dog will normally have 8 nipples, and a large hound has 10, because a normal litter is usually around 4 to 5 puppies. Humans normally have 1 baby at a time, so it therefore follows that we have 2 nipples. Most but not all animals have an even number of nipples. The opossum, for example, has 13 nipples, blowing the theory of divisible nipple numbers out of the proverbial biological window. But let's overlook that for the time being. The pressing question is, why do male animals, who we assume cannot usually produce milk, also have nipples or teats? It all starts in the womb. While men and women eventually grow and develop to have separate features, they do begin from the same genetic blueprint. During those first few weeks inside the womb, both men and women look pretty much the same, with shared features including, you guessed it, nipples. After about 6 weeks, a Y chromosome gene kicks in some changes in the fetus, including the development of the testes in the male, and after 2 more weeks, the genetic activity of cells in the genitals and brain begin to change, but by that stage, the nipples are here to stay with both males and females. But human growth and development scientists can't tell us why exactly men keep this vestigial body part that serves no evolutionary purpose to the male of the species. Well, at least most of the time. The vast majority of men don't lactate, but some do. Due to hormone imbalances, some men have been known to be the unwilling bearers of milk and in rare occasion may actually be able to feed their offspring through chance. And why shouldn't this be so? Men do have milk ducts and some mammary tissue, and through excessive breast pumping and nipple stimulation, a new movement of men, known collectively as milkmen, are also able to manipulate their man boobs into suitable suckling appendages. In a study called Male Lactation, Professor Patty McAdam of the Department of Anthropology at the University of Toronto observed the following. It is possible and has been observed in animals and humans. In 1992, Dayak fruit bats were captured from a rainforest in the Krau Game Reserve, Pahang, Malaysia. Of the 10 mature males captured, each had functional mammary glands from which small amounts of milk were expressed. A breast is a breast. Male lactation is physiologically possible, and according to Dr. Robert Greenblatt, production in males can be stimulated by simply letting a baby suckle for several weeks. The phenomenon of men breastfeeding at will was explored in the 1978 book The Tender Gift by Dana Raphael, and subsequently a small movement of milkmen evolved. But this milkman phenomenon doesn't occur nearly enough to make it a biological necessity for men to have a pair of nipples, and so it seems rather to be an offshoot of and utilization of our quirky design rather than biological intention. So if men weren't supposed to have nipples, then why wouldn't nature take its Darwinian course and over the years men would lose the attribute of nipples through some kind of natural selection process? Scientists counter that by saying there's no real metabolic cost to having nipples, and therefore it is not exactly an evolutionary priority to get rid of them. Women do not refuse to mate with men who have nipples, so why would Mother Nature decide to be rid of them? Natural selection is not hovering around constantly with the aim to get rid of things we don't need. Quite simply, the presence of man's nipples is hardly a threat to the survival of the species. Nipples on men aren't really doing much harm. And perhaps as the world becomes a more liberal place to live, and with same-sex marriages now becoming more common, we are entering an age where 2 males might be biologically adapted physically to adopt and nurture a child naturally using the nipples that they were born with. Perhaps this is the reason behind the design. What we need to remember is that natural science evolution is never neat and tidy. Quite the opposite is true. Nature is messy and unpredictable with strange quirks, but usually nature has some long-term solid plans, including men with nipples.
Yeah, think about that milkman idea. Yes, we're going to talk about what brings about the changes and how we get lactation, but there are men that can actually lactate, and yes, it does require weeks of nipple stimulation. in order for that to occur. And so there's several accounts of that. And I'm going to let you Google that all on your own, but I do warn you of the trail that you might find when you Google men lactating. Yeah, I'll leave you with that one. We talked about this way at the beginning of the semester when we talked about hypersecretion from the adrenal cortex in utero of a sexually female fetus. And so we talked about that adrenogenital syndrome where you got that masculinization or that ambiguous genitalia. And so that was due to increased androgen production. Think about it, this whole sexual differentiation process, it can't be brought on by estrogen or progesterone because those are hormones being made in the mother's body. And so it's going to have to be testosterone. If testosterone is present, you get male genitalia. If it is not present, you get the formation of female genitalia. Which leads me to the question, what happens if there's a mutation in the SRY gene? I'm going to let you think about that and answer that question. Okay, so it seems like we've been talking about the embryological period forever and just kind of reminding you, we look at the second half, so now we have sexual differentiation by about week 6. It's going to be done by about week 20. But 2, remember we have recognizable face, ears, eyes, nose, fingers and limbs are going to grow, fingers and toes. We have all main internal organs developed by the end of the 7th week. The head is going to be much larger than the rest of the body. The end stage of the embryonic period, there's a reflex action and a startle response because we started working on that nervous system really early. It is less than 1 inch long from crown to rump. I believe it said the size of a big blueberry, and it weighs about 0.06 ounces. So yeah, so they're just showing you embryo at week 7, about 17 millimeters long. Okay, so the first trimester is the most critical time of a pregnancy just because of all that cell division, we're growing in size, we have movement and that differentiation. And so teratogens are factors that cause congenital malformations by affecting the embryo during this period of rapid growth and development. And so, you know, it could be drugs, viruses, radiation, alcohol, vitamin A can even do it. So this is just showing you some ones that were really common. So Accutane was a medication that it's still currently given for acne. But notice that when the teratogens disrupt normal development in that first trimester. And so if you pop up here, if someone is on Accutane and sadly they found it out the hard way, you get brain, heart, and face deformities. And so if someone's placed on this now, if it's a female, then they're also placed on birth control. Diethylstilbestrol, also just shortened as DES. It was a synthetic estrogen to basically prevent miscarriages. And so its effect, so we would take that to prevent miscarriage. And so it affected the first 5 months. And what happened is it really affected the reproductive system. And so just abnormalities, structural abnormalities with the genitalia, high cases of vaginal cervical cancer, a lot of ectopic pregnancies, preterm delivery, high infertility, even for sons as well, high infertility, and then genetic abnormalities, so genital abnormalities. Thalidomide, this particular drug, it was given for morning sickness and was also billed as a mild sleeping pill. This was big in the 1950s, that it was supposed to be safe for pregnant women. And this is when they learned about the difference in stereochemistry, so isomers. It was a mixture of both isomers, so right and left-handed molecules. And they realized it was the left-handed molecules that caused these limb deformities. So you can see where it's active. Yeah, so being born without upper and lower limbs. And then, of course, another one is going to be alcohol. And so, yes, so this is the number one. So you see these signs, drinking alcoholic beverages during pregnancy can cause birth defects. And so, yes, fetal consequences, yeah, are long lasting. So it's called fetal alcohol syndrome. And it's just sort of a typified look of someone with fetal alcohol syndrome, but usually smaller head, so microcephaly, intellectual disabilities, abnormal growth. It is estimated that 1 in 100 babies being born are on the fetal alcohol spectrum disorder, nearly the same rate as autism. And they believe this is the #1 preventable cause of intellectual disability. So it is very important that a pregnant mother does not drink alcohol because it easily crosses the placenta. All right, so fetal development, 9th week to birth. Yeah, you're like, wow, you hardly said a thing about it. Yep, sorry. Pretty much everything's just going to get bigger and is going to develop more fully. And so by the 3rd month, like I said, the sex can be seen. 4th month, we're going to get ossification of that hyaline cartilage skeleton. 5th month is usually when the mother can start to feel movement. There's 2 things that are also occurring. So as the skin's developing, you think the baby is in the amniotic fluid, which is going to also be filled with fetal urine soon. And so there's something called vernix caseosa, which think vernix like varnish of cheese. And so this is a waxy white coating from the sebaceous glands, basically going to protect the skin. Also, all over the body, there's going to be these white little downy hairs called lanugo, and they think that that helps hold the vernix caseosa on the skin. Also, hair will start to grow. Some babies are born with a full head of hair. 6 months, you also have fingerprints. What else? 7 months, yeah, testes descend. Remember, we talked about the testes starting their descent. By the 7th month, we're going to get some red bone marrow making some blood cells. And then, of course, the 7 to 9 months, we're going to get waking for the fetus. A fetus is considered full term at 37 weeks. And then 2, it's that week 23 that they begin to make surfactant, but week 27 potentially viable, even though much earlier births now they're getting better with that neonatal care. But typically, you want to at least make it to 27 weeks for the infant to have a good chance of living. But usually weight is about 6 to 10 pounds and height roughly around 21 inches. Whew. All right. So anatomical and physiological changes for mom. Oh, just a few. So this is showing you uterine growth. So before conception, the uterus is about the size of a fist or a small pear. But as the baby develops, you can see that the fundus, the dome part, they're telling you where it is. By the 4th month, it's halfway between the pubic symphysis and the umbilicus. But then 7 months, it's well above that. By the end, it can be all the way up, almost to the xiphoid process. And so the ribs are going to flare out, the thorax is going to widen, and with this extra weight, hopefully that round ligament is doing its job of keeping the anteversion. What can also occur is called lordosis, and so that's exaggerated lumbar curvature. There's also going to be some hormone called relaxin that is going to cause those pelvic ligaments and the pubic symphysis to relax to ease the birth passage. And it's also thought this might be relaxing some of those sphincters, maybe one of the reasons women get heartburn when they're pregnant. There's some conflicting things, but they kind of think that. All right, so weight gain for the mother, about 28 pounds is usually seen. So you think you got the fetus, you got the amniotic fluid, you got the placenta. The uterus, of course, has grown during this time, and extra water and fluids. Good nutrition is going to be vital, but really it's only about 300 calories that are going to be necessary to increase that per day. And it's really important more so what the woman eats. So it's going to use a diet needs to be high in protein and calcium and iron, definitely folic acid. Is a big thing in preventing spina bifida, and good nutrition can also help prevent preterm birth. So let's talk about placental hormone, human placental lactogen, so HPL. It has another name, human chorionic somatomammotropin, which is just a fun word to say. But the placental lactogen, that kind of gives you a clue. So we're going to get the origin of lactation. So it's going to stimulate the maturation of breasts along with estrogen and progesterone. A woman's breast can basically double in size. So there's going to be greater development of the ductwork and also those alveoli making milk. So the estrogen, progesterone, and placental lactation, they're just all going to work together. We're also going to get some changes from that hormone as well. So we get some fetal growth, and then also glucose sparing. And it's believed that it could be the placental hormone. It could be human placental lactogen that may be the cause of gestational diabetes as well. Other things going on, parathyroid hormone and vitamin D levels are going to stay really high throughout pregnancy to ensure that there's adequate calcium for fetal bone mineralization. And so remember, parathyroid hormone is released when blood calcium is low, and so that just stimulates the osteoclast activity for the mom, that reabsorption of calcium from kidney tubules, and then to activating vitamin D so we get better calcium absorption. So in this little time of development, if the fetus needs calcium, the fetus is going to win. And so that calcium is going to be taken from the mother's bone, so it's not uncommon for pregnant women to have soft bones or osteomalacia. So let's talk about the gastrointestinal system. Morning sickness, heartburn, and constipation are some of the things mothers have to look forward to. And so we kind of already talked about morning sickness. Like I said, it kind of makes sense when you see the high levels of HCG and how they drop after that first trimester. Some women do, however, they're nauseous the whole time, and that could be due to the increasing levels of estrogens and progesterone. Two, as far as I was just looking at this picture. So see, as the fetus is starting to grow, the abdominal organs are going to start to get compressed. So you can see how easily that this could cause pressing on the stomach, so you get that weakening of that lower esophageal sphincter, so you get heartburn, and also compressing of the intestines, so why a woman could also have constipation. And so it's just kind of showing you the better picture of that. The urinary system, think about it, the blood volume is going to go up, so a mother can go from 5 liters to 7 liters. So there's more blood to filter. And then two, so a woman's going to have increased urine production because she's also, because of that volume, but she's also filtering out fetal waste as well. The rest of the problem with the urinary system as far as incontinence goes and urgent urination, location. So this is, remember, this is going to be the uterus, the womb. Oh, look, there's the urinary bladder right here. So as this baby is moving, the detrusor muscle can get stretched, that internal urethral sphincter can open, and depending upon how much pressure there is, that external urethral sphincter can also open. So if you see a pregnant woman and she is waiting in line to use the restroom, might be nice of you to let her go first. So let's talk about the cardiovascular system. Like I said, increased blood volume. Think about the blood. We have to provide enough blood to go to the placenta. And so like I said, it can go up from like 5 liters to 7 liters. So clearly, since we're increasing volume, we're going to increase in cardiac output. We talked about problems with that return, venous return, and those varicose veins, the failure of those valves. Other things that's going to happen, there's going to be increase in clotting factors, which is good because there's some bleeding associated with that birthing process. Increase in red blood cells, so hematocrit's going to slightly go up. The heart rate is also going to go up, so resting heart rate will be about 80 to 90 beats per minute for the mom. Other things too, that tidal volume is going to increase by about 40%. So pregnant mothers are going to take a bigger breath in. The problem is going to get a little difficult as that baby starts to fill up the abdominal pelvic cavity, depending upon how much room that mother has. Remember that diaphragm may have trouble flattening out. So late in pregnancy, you might get some dyspnea or some labored breathing. I just kind of remind you. So just kind of show you, remember that normal tidal volume, normal breath in, normal breath out. And so yeah, that tidal volume can increase by about 40% when a woman is pregnant. Okay, since we're talking about the cardiovascular system, there's a common problem that occurs in pregnant mothers, so 1 in 10, and it's called preeclampsia. This is a complication. This can result in deterioration of the placenta and insufficient placental blood supply. And so they don't really know why this happens, but if you kind of look up here, so this is showing you normal delivery. So it's showing you that there's a membrane there. Remember, there's no mixing of blood, but you've got these arteries going to the placenta. And so it's showing you nice big blood flowing into those open spaces. And then you've got the chorionic villi sort of dipping down into them. And then that blood leaves by maternal veins. And so if you go down here, so what happens in preeclampsia, and they don't really know why, but there's going to be a narrowing of those arteries going to the placenta. And so what this can do, this can lead to the fetus being starved of oxygen. So there's just not enough oxygen-rich blood going to the placenta for the fetus to get enough oxygen. And so there's 3 cardinal signs of preeclampsia. And so PRE, so proteinuria, so proteins in the urine. The mother is going to have high blood pressure, so hypertensive. And then you often see swelling, so edema, particularly in the lower appendages. So these 3 things together are a bad sign. They think it may be due to immunological abnormalities. Like I said, they don't really know why this occurs, but it is common. It occurs in 1 in 10 pregnant women. So it could be due to genetics, nutrition, excess weight, but to be honest, they really aren't sure. Clearly, preeclampsia is a problem. It depends when in pregnancy it occurs. If it's later in pregnancy, they may deliver early. A woman may become bed rest. They may just try to control the blood pressure. It really just kind of is going to be on a case-by-case basis. But clearly, dangers of the baby not getting enough oxygen could be low birth weight, preterm delivery, risk to the mother, seizures, death. Don't know if you're a Downton Abbey fan. That's what happened to Sybil. If you've never seen the show, don't worry about it. But just the later in pregnancy, if this is going to occur, is better than earlier in pregnancy. And like I said, they really don't know why this occurs. All right, so we're almost, we've made cave kid, we've had fetal development, and now it's time for labor and delivery.
During a vaginal childbirth, the first stage of labor lasts about 12 to 19 hours and starts when your baby settles lower into your pelvis. In response, your cervix begins to efface or become thinner and dilate or widen. During this time, you may feel strong, regular contractions occurring every 5 to 20 minutes and lower back pain and cramping that doesn't go away. You may see a brownish or reddish mucus discharge, which could be the mucus plug at the opening of your cervix, falling out. Your water may break, which can either be a large gush of fluid or a continuous trickle. If you experience any of these symptoms, contact your doctor or midwife to see if you should go to the hospital. At the beginning of stage 2 of labor, which usually lasts from 20 minutes to 2 hours, your cervix is fully dilated to 10 centimeters. And your baby's head has moved beyond the cervical opening into your birth canal. Your doctor or midwife will instruct you to push during your contractions and rest between them. In a normal delivery, your baby's head will rotate to face your back. During active labor, your uterus is divided into an active segment that contracts, pushing the baby downward, and a flexible passive segment that remains relaxed, stretching to provide more room for the baby to pass through. When the top of your baby's head appears, or crowns, your doctor may make a small cut, called an episiotomy, to enlarge the vaginal opening. Then, your doctor or midwife will give you instructions on how to push your baby out. As your baby's head passes through the birth canal, it molds into an elongated shape. An elongated head shape will resolve itself within a few days as the skull bones shift back into place. After your baby's head exits the birth canal, his or her head and shoulders will rotate to help the shoulders pass through the birth canal. Your baby's shoulders are delivered one after the other in order to fit through your pelvis. Once the shoulders emerge, the rest of your baby slides out easily. After your baby is born, his or her umbilical cord will be cut. In stage 3 of labor, which may last 5 to 30 minutes, Mild contractions will help push the placenta out of the uterus. During this stage, you and your baby may begin bonding through skin-to-skin contact and breastfeeding.
Okay, so let's look over here. Let's look at what's happening. So we have estrogen, we know is going to be made by the placenta, and estrogen levels are going to go up throughout pregnancy. And so that's going to induce oxytocin receptors on the uterus, particularly the myometrium. And so they really don't know what exactly brings on the onset, but we know that there's going to be a slight drop in progesterone at the very end, increasing estrogen, and then two, we're also going to get some prostaglandins from the placenta. So we have oxytocin from fetus and mother's posterior pituitary, stimulates the uterus to contract, also stimulates the placenta to release those prostaglandins. So we get more vigorous contractions of the uterus. As that cervix gets stretched again, we get this positive feedback that's going to cause more the release of oxytocin. And so oxytocin is that main mediator of labor. And like I said, it's that positive feedback. It's that further stretching of the cervix that's going to just send that message, and it's going to cause that release of more oxytocin. And so those uterine contractions are just going to keep pushing that fetus forward, causing the cervix to stretch and to dilate. And so that stage one, like I said, it's going to be the longest stage of labor. And so the onset of labor to complete the full dilation of the cervix. And just kind of showing you before labor, some of the cervix is just this neck portion of the uterus. And so it's going to get thinner, or what's called effacement. So it's 30% effaced, complete effacement. And so women can walk around, effaced, even partially dilated before they go into labor. But usually it's going to be that expulsion of the mucus plug is usually that first sign that birth is imminent. So that's as that cervix is effacing. If the amniotic sac ruptures, then labor is going to start. Sometimes women begin labor before the amniotic sac is ruptured, and then they may rupture it. But like I said, labor is marked by those regular, long-lasting contractions, and that is to basically dilate the cervix 10 centimeters. So birth and delivery, and so we saw that just on the video, but an episiotomy is going to be those incisions that the doctor makes. And think about the vaginal orifice. It is not the size of a baby's head. And so it's much better for the mother post-delivery for healing purposes if this is a clean cut rather than a tear. And so that's the function of the episiotomy. So we have delivery, and then after that, stage 3 is called afterbirth. And so it's going to be about 15 to 30 minutes after. So once the baby exits, what's going to happen to those vessels going to the placenta is they're going to constrict, and that's good. That's to prevent the hemorrhage of a woman. A woman's going to continue bleeding after birth for about 6 weeks, because that is basically a wound right there on the uterine lining, so that endometrium. So the decidua basalis, that functional part of the placenta, is going to disconnect and then be delivered as afterbirth. And we saw a picture of what that looks like. Whew, okay, so we have cave kid. All right, so now we're going to get milk production and secretions. And so breasts are basically fat, the alveoli that make the milk, and then of course the duct work. And so we already said estrogen, progesterone, and that placental lactation are going to promote that mammary size development. And so those breasts can double in size. And so this is just kind of showing you pre-pregnancy, and you see the glandular tissue and connective tissue. And then notice it's going to get very much larger and way more glandular tissue with their secretions of milk. And so it's going to be progesterone that's actually going to inhibit true milk production until delivery. Okay, so this kind of walks you through it. So before pregnancy, beginning of puberty, we have ovarian hormones secreted that will stimulate those alveolar glands and ducts of the mammary glands to develop. Okay, so men don't have this. And so back to the milkmen, while they can still have secretions coming from their breasts, no one's really done a nutritional study to see if it's, of equal nutrition. During pregnancy, estrogens cause the duct system to grow. Progesterone stimulates alveolar glands to grow, and placental lactogen promotes development of breast. So these are all going to be synergistic. They're all going to work together. Prolactin, so pro means you're for something, lactation, the actual act of making milk. It's secreted throughout pregnancy, but placental progesterone is going to inhibit the actual milk production. And so prolactin, remember that was one of our hormones coming from that anterior pituitary. So it's always being made, but it's going to be inhibited by progesterone. And so it's not till after delivery their inhibition is no longer there. So that placental lactogen, once we have afterbirth, we no longer have that placental lactogen. So it's trying to help you between prolactin and lactogen. Gen is the genesis or origin of lactation. That's just getting ready. So it's not the actual stimulation of milk production. It's prolactin that actually stimulates the production of milk. And so what happens after a woman delivers, she doesn't have true milk. She has what's called colostrum. And so for the first few days, it's just going to be colostrum that is made. And this is actually, it's perfect for the baby with their immature digestive system. So it's going to be low volume, really nutritious, high in IgA antibodies as well. And then, so a woman has to wait for her milk to come in. And so that's when you get enough prolactin and you get enough time for actual milk development. So prolactin from the anterior pituitary, you're actually going to get that milk to be produced. All right, I just love people that throw stuff like this on the internet. So someone took a picture of their breast milk, so awesome. So this is colostrum, and so like I said, it's thicker, it's yellow, it's creamy. Just think that newborn, the first time they suckle and they eat, so they get a lot of nutrition for not much volume. As the baby grows too, so this is first milk, they're showing it 3 weeks after birth, so whiter, thinner, so just it's going to change. So right away, a woman doesn't have true milk, she has colostrum. Okay, so the act of breastfeeding once could be all hormone driven. So there you get stimulation of those mechanoreceptors in the nipples by suckling. And so the infant, we're going to get a message sent. Hypothalamus is going to secrete prolactin releasing factors. Goes the anterior pituitary, goes, oh, okay, we've got a baby now. So prolactin. And that's going to target the mammary glands. And so that's when we're going to get some milk production by those alveoli. Also, what's going to happen, the hypothalamus, the captain, is going to send nerve impulses to the posterior pituitary and cause release of oxytocin. So oxytocin is our human bonding hormone. We really want mom to bond to baby because this baby is going to wake mom up. It's going to cry. We want to make sure mom loves the baby. All right, so we get a release of oxytocin. What this causes is what's called milk letdown. And so those myoepithelial cells, and so it's showing you this little, they're kind of like smooth muscle cells around these ducts. They're going to contract, and then the milk is going to go into those lactiferous ducts. And so that's called milk letdown. And then the baby's going to suckle out the milk from those ducts. And so it's all going to be based on positive feedback. So if a woman does not breastfeed, it's important that she has no stimulation to those nipples, and then eventually a woman will stop making milk. So that's going to turn off milk production. So if you want to breastfeed, then the mother needs to have nipple stimulation. Woman that doesn't want to breastfeed, then it needs to not have that nipple stimulation. Other things about breastfeeding, we talked about the advantages to the baby. It also helps return the uterus to the pre-pregnancy size. It also helps the mother. Also, too, just the excess calories that it takes also help her lose some pregnancy weight. Okay, so following childbirth, placental hormone concentrations decline, so the action prolactin is no longer inhibited. Breasts begin to make milk. Mechanical stimulation of the breast releases oxytocin from the posterior pituitary. We get milk let down, or that release of milk from the ducts. As long as breastfeeding continues, more prolactin will continue to be made. The nipple is not stimulated, regularly milk production ceases. Other things about prolactin, and think about this biologically. If caveman, cavewoman, cave kid, if a woman already has a baby suckling at the breast, it's probably a good idea to not have another one. You know, she only has 2 arms, she only has 2 breasts. And so prolactin inhibits gonadotropin releasing hormone, follicle stimulating hormone, luteinizing hormone. So that means as long as a woman is breastfeeding, she will not ovulate, nor will she have a menstrual cycle. And so it acts as birth control. This is if a woman breastfeeds continually. So, not just sporadically, but full time, to make sure that there's enough prolactin and that inhibition. So for it to act as birth control. That kind of makes sense biologically. So if a woman chooses to breastfeed, there are some things that are contraindicated or advised against. So use of drugs. Clearly, obviously, chemotherapy is probably not something that is going to be compatible with breastfeeding. Barbitol, probably not a good thing as well. Spasms, sedation for the baby, birth control as far as can get decreased milk production for the baby. Caffeine in large amounts can also affect sleep in the baby as well. Clearly, cocaine, ethanol, heroin, even nicotine, these are all things that are advised against if a woman is going to breastfeed. So those are all things you'll have to be advising your patient against. Oh my gosh, it is our last slide. How amazing. I love Far Side. But I do want to tell you, now that we've finished this, how amazingly special you are. You consider that 1% of oocytes are released in the abdominal cavity. 2/3 of fertilized eggs fail to implant properly. 30% miscarry. 20% of oocytes and 3% of sperm have an abnormal chromosome number. So if you are listening to this and you are here and you have 46 chromosomes, you are special and you are no accident. And so just kind of wanted to share that with you. And hey, great job, everybody. This is it. So just the final exam left. Have a great day.